Good afternoon in the Philadelphia and East Coast. I want to welcome you to the 7th edition of the Academy of Osseointegration Hotseat Podcast. We explore the minds of influential leaders shaping the future of our profession. Today, we are honored to welcome an exceptional guest, a good friend, as well as a true pioneer in her field, Dr. Irena Sailer. Dr. Sailer presently serves as the head of the Division of Fixed Prosthodontics and Biomaterials at the University of Geneva, a position she has held since 2013. She also has a U.S. connection as Senior Associate Dean for Digital Transformation at the Columbia University College of Dental Medicine. Her contributions to the field are extensive, including over 150 peer-reviewed publications, editor-in-chief of the International Journal of Prosthodontics, and co-author with her husband, Vince Firmer, of the recent textbook, Fixed Restorations, a Clinical Guide to the Selection of Materials and Fabrication Technology, that was published in 2021. Irena also holds several patents related to dental technologies. So in this episode, Briar Voy, who is our co-host, my co-host, we will explore three key topics: leadership and mentoring, how Dr. Sailer's approach has influenced the growth of our profession. 2, the evolution of digital dentistry, including her early adaptation of biomaterials, including zirconia, and digital dentistry, and how it has changed her life. And 3, future of prosthodontics, implant dentistry, and biomaterials. To close, as we've done previously, we'll each share book recommendations, insightful reads, or better yet, audiobooks you can listen to in your car while traveling that will inspire and energize you on your journey of lifelong learning outside of dentistry. Dr. Sailer, let's start with your story. Can you take us back to where it all began, where you were born, grew up, your mentors who empowered you on your path to your current role? Thank you for joining us, Irena.
Thank you very much for having me here, Bob, and also Briar. It's a huge pleasure to share this hot seat webinar with you. And the preparations for this were already exciting enough. And I cannot thank enough to the Academy of Osseointegration, of course, for having me here. And also both of you of being my host and co-host for this really, really cool session. I think it's a great idea. Well, my background is a very, I would say, colorful one, because I was born as a child of immigrants, Yugoslav immigrants in Germany. And so I grew up with parents who just came to Germany and in a very Yugoslav environment at home. And I learned German at the age of 5 when we started going to kindergarten and then school. So I already grew up with having a little bit of a split mind between two mentalities, between two countries, between two languages, which I think today, retrospectively, is a huge advantage. And then I went to school, of course, in Germany. I studied dentistry at the University of Tübingen, my alma mater, and I graduated from dentistry in Germany and started looking around the private practices around Stuttgart, which is not far away from Tübingen, to see whether I could find the practice where I would really sort of fulfill my dreams of becoming a fantastic dentist. Because for me, it was really the excellency of dentistry, the excellency of prosthodontics was something that already influenced me in the beginning and really sort of motivated me to go further. And then while searching around, I learned about Peter Scherer and his clinic at the University of Zurich. I've seen their work. I visited them once. And I knew exactly this is what I would like to do. This is the level of dentistry that I would like to learn and pursue. And I really I did everything that I could to get into this clinic and learn from this first mentor of mine.
It's interesting how the first person, Dr. Peter Scherer, is very, very well known internationally, how he influenced your life, like from day one when you first met him.
Well, it was such a struggle just to get him notice me, because he had, of course, a long line of people waiting for positions to be in his postgraduate program, even volunteers who would be willing to do this for free, coming from all around the world. He was so famous, and his team around him was so brilliant, and he had such great quality of technicians also in his clinic, that it was really, really, it was not easy. So I had to overcome a little bit my shyness and a little bit, my restrictions of being a little bit too pushy, and I had to sort of make him aware that I'm there, that I would really like to come and even for free, no problem.
Wonderful.
Yeah. And this is how it started. So I started visiting his clinic every couple of weeks for 1 day or two, shadowing him and his team. And each time he had a different news for me. First time he said, well, yes, maybe we can make it happen. Yes, we will find a solution. Then a couple of weeks later, when I came back, he said, well, no chance. Everything is full the next year. So he was really sort of playing with me to see whether or not I would be really, really willing to come. And in the end, I realized, well, after a couple of months, it was really getting difficult. My parents were pushing me. You have to find a job. You have to start working now. You graduated. And I wanted to be there. And while being there, I learned the easiest way to get into the whole system of the University of Zurich at that time. And that was 98. The borders were not as open as they are today for foreigners. It was to work as a volunteer postgrad student in the oral surgical polyclinics, because they had so many patients and they had a real need for dentist volunteers to support them. And I applied for such a position also on a non-paid level, and I got it. And then I was there, and Peter Scherer would have to see me every day in the cafeteria, because I was at the University of Zurich in the oral surgical department. And I did 1 whole year oral surgical postgraduate training, which was an excellent preparation for everything that followed afterwards. And then, of course, while being already at the dental school and while sort of being a little bit more visible to him, I became a little bit probably inevitable for him. So at some point, he allowed me to join the team on a voluntary basis. Yep. And this is how I could start in 1999, after 1 year of surgery, in prosthodontics, and start really learning the excellency of our profession, the excellency of dental technology, the excellency in material selection. And with this, also over time, technologies came in. So it was
wonderful story of determination. So congratulations, Irena. All right, great.
Well, I cannot tell you why it happened, but I just felt this is the right way to go. And when I was there and I got infected and I started being used by all the researchers to be assisting here, taking photos there, because I was a free working horse. It was the best time for me because I could learn from everybody that I could assist, that I could take photos for. And I got infected by this virus of doing research, having questions, and from one question, 10 more questions, and more and more and more. And that's, in the end, how I stayed on at the academic pathway.
Congratulations.
Yeah, thanks.
The stories are very inspiring, Irena, for especially the younger generation. And I know Briar could value that as well and understand that from her own personal experiences in dentistry. So
yes,
sounds like similar paths. Yeah.
And utilizing the resources you have to continue to learn more and push yourself and push the boundaries. And now you're a mentor that many people are wanting to be able to learn from yourself. So that's quite incredible.
Know what? I think you need a support. You need your family support, of course, because I just finished studies and my parents were hoping for me to get a job and start working and get me off their shoulders. And then I decided to go to Switzerland and continue working for free. And this not only for 1 year, but for 2.5 years all in all. So I applied also for a grant. It's like a German grant by the German it's the German exchange service for students, where you could apply for grants, you would go through interviews. And in the end, I got a 1 year grant, which at least financed part of my living in Zurich for 1 year. And it was a great help already. And it was a wonderful start, but I cannot thank enough my parents for having opened this door for me and having allowed me to go this pathway. Because without them and their support, I couldn't have done it in the beginning, which would have ended the whole thing in the beginning already. And so this is, I think, a most crucial step. And then the grant, of course, by the German government was also very helpful. And I always try to give back as much as I can. And then you get into the system. And if university really infects you with this beauty, what it is, with all the different opportunities, possibilities that you have, that you're at the forefront of everything, that you learn about things before even they get on, into general practice levels, and that you can work on those and maybe even at some point influence their development and improve them. And This is, I think, very rewarding, and I'm very grateful for the whole way, but also very grateful for the University of Zurich that they gave me this opportunity. And Peter Scherer, I will never forget. He was such a visionary, and for me, it was such a wonderful first mentor. He was so, I don't know, he had a really good sense of who to put onto which project and how to promote people, and at the same time, how to benefit himself also from the output of his team, which was amazing. You know, many, many names that came out of his life at the university. Exactly. Yep. And he was the one who put me onto technologies in the first place in 1999.
Love to go to the next slide to be able to talk about that more.
Yeah, on this topic, I got a question for you. What are your thoughts about AI's future influence in treatment planning and execution from single tooth, which you're going to present here, to full mouth reconstructions? I know we're going to cover a lot of this today.
Well, AI, I think, is all over, and I think AI influences already a lot of the technologies that we're using, from optical scanning procedures to designing. And I think it will continue influencing all these treatment, I would say, propositions or treatment pathways more and more in the future, because things get automated. In the best case, we will have reliable and validated software at hand that will help treatment plan the right thing for the right patient in the right indication, and that will guide the clinicians through the procedures. And we will have tools at hand really to be very predictable, and also high-level dentists all around the globe and independent of maybe the level of education. But it will take some time until there.
So I want to continue with this case, Irena.
Well, that's a case that really nicely shows how technologies today, they help improve efficiency of treatments. They help reduce sessions that the patient has to come back to the clinics. And I think this is just simple. You asked me to put in a simple case in the beginning, and I think this is a very straightforward situation. Patient has a molar to be replaced. The implant was placed in a prosthetically oriented position using a classic conventional surgical guide. An optical impression can be taken already at time of the surgery, which avoids a second meeting already for the patient. And then we can either go to immediate loading if the implant and its primary stability allow for it, or if not, we can mill a restoration that we design on the screen according to the anatomical situation of this respective patient out of a resin. We can take it out of occlusal contact, so it's not loaded, but it helps us stabilize the gap size, and it helps us, develop the emergence profile already during the healing of the site. And it's the design that we will then finalize, which you can see on the next slide, after a couple of weeks, by milling now the whole crown out of a final reconstructive material, adhesively cementing it to tie base abutment. And for the clinician, it's a all ceramic restoration, a screw retainable single crown on an implant with a metallic insert in an already customized soft tissue profile. So it's easy to put it in, it's not painful, no anesthesia, and it's a straightforward procedure. And I think this is a lot thanks to technologies today. They really help us be more predictable, be more efficient, and I hope also less expensive.
And beautiful soft tissue response here. So as periodontist, I truly appreciate that.
Well, that's also material and treatment of the material, which makes it. Yeah.
Absolutely.
Yeah.
Yes, and I can see here, it's very highly polished, all the areas that are in contact with the tissue. You can see there's no glaze, but just a really high glassy polish.
Yes, maybe if you go to the next slide, I don't know if this maybe a little bit, no, it's not more visible on that slide. It's the submucosal part underneath the mucosal margin. They're just high gloss polished virgin zirconia in contact with the soft tissue. And this is well documented evidence-based that the soft tissues, they react very well to zirconia, high gloss polished, not too glazed, not veneered. So it doesn't look nice when you look at it from the bottom because it has a different, maybe a little bit a different shade than the rest of the tooth, but biologically is the best that you can do.
The emergence profile is perfect, and my controllabilities. Question about the occlusion on this tooth. Could you describe how you do the occlusion on number 30, the lower right molar, versus the other teeth that are natural teeth?
It's the same occlusal pattern. It's the same occlusal load. We have no difference. The implant is osseointegrated. If it's an immediately loaded situation, it depends a little bit really on the stability of the implant and the implant design. We may have a little bit, maybe less occlusal strength contact on the respective crown. But in principle, there is no need to treat this implant differently than the teeth next to it, or this implant crown differently than the teeth next to it.
Great. Thank you.
So this is how I met Peter Scherer, who was in his last years of his professorship at the University of Zurich. So I could accompany him for 1.5 years, and then he retired. And that was a little bit for me the question, will I stay in Zurich or should I go back to Germany and then really start working in a private practice? And then when Peter Scherer left, some of his key faculty people left with him and went to private practice, and some of the postgraduate students became promoted to faculty, and a paid position, postgraduate student position became available. And Christoph Hämmerle was appointed as his successor, coming from Bern. And I really also cannot thank Christoph enough to having offered me the opportunity to stay on and to be on a paid position, which then, of course, was a relief in all senses, because I knew exactly what I was aiming for. I could go through a 3-year structured specialization program with the team. I was on a regular position. I could a little bit, offload my parents. And it was, I think, a wonderful time. And the best of all was that during Scherer's era, there was a high level of prosthodontic excellence, aesthetics, perfection. It was incredible. Scherer would scream at us if we would have photographs, and it was not digital photos, Briar. It was like conventional photos taken during interventions or surgeries where you would see a little bit of saliva on it. So he really trained us to be perfectionists to the highest level. And this perfection was then with Christoph combined with a lot of scientific knowledge and evidence. And Christoph was really a fantastic next mentor, because he realized what heritage he had with Scherer's era, and he added the scientific part on top of it. So we could combine the best of both worlds.
Sure.
And the time in Zurich with him, all in all, it was then 15 years that I was in Zurich, were so enriching and so inspiring, with such great team spirit. And you could really, we were all working together. I became faculty at some point, and then we were working together on raising this clinic into the skies. And it was a great atmosphere. It was great spirit to be there.
Great. Next slide, please.
So Scherer, when he was retiring, he had, before just retiring, maybe 1 or 2 years before it, he had developed this direct ceramic machining process together with a group from the Federal Technical Institute in Zurich, some ceramists, Professor Filzer, Kocher, and Gaukler mostly, and they had developed the first white stage milling procedure, and then sintering to full density and the right shape, right size, and the right position of zirconia. Zirconia was already used by then, but it was used in the fully densely sintered stage, and it took long hours for the milling machines to mill the restorations out of the block, the fully sintered zirconia. And they had the idea to develop a process where you could mill it in a stage where it was like a chalk, a little bit softer, and then sinter it to full density by knowing exactly all the parameters that would be needed for the sintering shrinkage to then bring the restoration into the right accuracy and into the right shape. And it was I would say, groundbreaking development, which really made zirconia to what it is today. So it was just about, they had published this, they had patented it, they started a clinical study, and Scherer was retiring. And then he just gave me all this area of zirconia prosthodontic research into my hands to follow up on. And for me, this was the door opening to all the technologies. It was time, it was like 2001, 2002, when CAD/CAM procedures were not as accurate yet, and the bridges were not super accurate that we had milled and processed with this procedure. And the clinical study was sometimes a little bit disappointing, because you could put the bridge in sort of in patient 1, patient 2, patient 3, same clinical situation, because it was so loose. So I was believing very much in it, but many people around me didn't believe in the technology, and also into the need to have a ceramic material to do bridges. But in the end, I think it proved us right over the years. So if you go to the next slide, I was lucky enough to really be there in the era of zirconia, and I could follow the whole development and evolution of this material and also the associated technology, because this material could only be processed with computerized technologies. And that's why I was into CAD/CAM already early on, when it was not working well, and we had to develop the preparation techniques for CAD/CAM procedures. We had to develop the veneering techniques for zirconia, and they stayed a problem all through my career in Zurich. We had to develop the adhesive cementation procedures and protocols. So it was a huge area to explore, and it was a great time.
At what point did you start to think that maybe lithium disilicate would be replaced by this zirconia?
Well, if you go to the next slides, I can show you a little bit the outcomes of the studies. So this was the technician situation at that time already. And you could see one working with his hands and the other already on the computer. And I think today you see them almost exclusively working with computers and just a little bit of stain and glaze, maybe microveneering. But that was really like a change of mindset. If you go to the next slide, I can show you a bit the inside of what we had done at that time. So I inherited the study, which I then followed up. It was a prospective study. It was not controlled. It was the first case serious in principle with this new type of bridges into clinical situation. And we had a 5 and a 10-year outcome that we published. And I was really the one who had to take care of all the complications with all these patients. And there were quite some complications, I have to say, because we had very good framework performance, but low, I would say, survival rates of the veneering ceramic. So a lot of chipping. We had caries on the margins because the patients were not in a regular maintenance program. And also the bridges were not fitting very well. We had some marginal openings and some degradation of the adhesive cementive borders. So it was really a difficult time to believe in this material. And that's why, I think at that time, lithium disilicate was already existing, but this whole EMAX system was invented and then presented to us. So we were invited to visit Ivoclar and look at their newest development. And we were wondering whether this lithium disilicate material could be an alternative to zirconia in these indications, because zirconia had problems with the veneering ceramic chipping. And if you go on to the next slide, Christoph, of course, in the first place said, we have to publish this. I published all the complications. We were hit by the developers of the system quite hardly because they were not happy with us to publish all the problems. But in the end, I was happy to receive this notice by, I don't even know by whom anymore, that this paper was on the number 14 of the 100 most cited articles in prosthodontic journals in a paper published in JPD in 2020, I think, or 29. Well, in the end, it proved me that complications are part of the research in prosthodontics, and if we publish the complications, then we can make the field evolve. So Christoph's first step into this, go maybe to the next slide, was we have to have a controlled clinical trial, because this is a case series and it's prospective, but we don't have any control. We see a very good framework performance of zirconia. We see maybe a few fractures, but if they fractured, it was also because the design was not correct and maybe there was some iatrogenic problems with it. Maybe go on the next slide.
Irena, could I ask a quick question? Because this goes back to your personality and your determination. If it wasn't for your determination, we may not have zirconia at this time or a much later time, because you realized it had potential, but you realized you had to report all the complications. I think that's a really good story for the young clinicians that are listening, the young researchers. You got to tell the truth. You got to share the data. And with your determination, let's keep going. Let's keep heading that way, because I know we could get there.
And the thing is, you have to believe in what you're doing, Yeah. If I would have had any doubts in this, I wouldn't have gone through all the difficulties that we had, but I thought it's such an interesting time because we have so many things to learn. We didn't know how to do the connectors and what the sizes were, and so many things that could be improved. So my wish was to improve it. And with a lot of researchers around me, of course, that also worked on zirconia that had the same problems, I think that now it really became something super interesting, zirconia. Yeah. Oh, and I think because of the success of zirconia, I think that we're in this digital era of dentistry, I guess. Yep.
And I think a big part of that, too, is by publishing those complications, you're also making note of them and able to excel and drive things forward to be able to manage those complications. So that was not only brave and like very, impactful, it probably expanded and exceeded where zirconia is today.
Yeah, but that's what you do when you're a young, naive researcher and you're passionate about what you're doing and you want to honestly report on what happened. There were quite some people around me that were not so happy with the reporting, you can imagine. But it's until today still my most cited paper, the first one with the biggest complication rates. And it's interesting to see that publishing something that is not pleasant to everybody can maybe help improve the field and raise interest and raise learning curves all around the globe, and that we should be really a little bit more brave in reporting on problems and helping improve the field.
Yes, thank you.
Yeah. Well, our next evolution, if you go to the next slide, Briar, or Jim, thank you very much, was to learn all these things surrounding zirconia restorations. How should we prep for CAD/CAM? You cannot prep it as the same way as you do it for a manually made metal ceramic restoration, because the milling machines and their instruments, they have certain dimensions, and the dimensions, they influence the preparation. So this was one of the discoveries. Maybe if you go to the next slide, besides the learning of how to design the connectors, we had to learn how to veneer the zirconia frameworks. The veneering techniques were improved, but the chipping rates didn't come down. So if you go to the next slide, whatever was done in the development of this restorative material on the material scientific side to improve veneering and the stability of the veneering ceramic failed. So after 12, 13, 14 years in this research on zirconia, showing that if you compare it to metal ceramics, it performs almost equally well framework material-wise. But if you look into complications, it's much worse. So if you go to the next slide, we learned really that if you compare it to metal ceramics, the zirconia bridges, even when fully developed, not prototype stage anymore, they still had more problems with fracture of the veneering ceramic, a little bit more debonding because of the fit, poorer marginal adaptation, but they had very good framework stability, considering that sometimes we had 5-unit posterior bridges with 3 pontics. This was absolutely unbeatable by other ceramics, so it was never there before. And I think this is a little bit the value of zirconia. It is much stronger than other ceramics when you apply it correctly and when you use the right zirconia and the right indication. Yes. So I think lithium disilicate, we just finished an update of a systematic review on the performance of all the ceramics that are used so far, monolithic, microveneered, or fully veneered on teeth. Lithium disilicate is a very high competitor to zirconia in single unit cases, but when it comes to multiple unit cases, it performs less well. So the zirconia strength, its fracture toughness, specifically the one of 3 yttria stabilized zirconia, is unbeatable. So that's what we're doing today. We're doing a lot of restorations out of zirconia and out of lithium disilicate, most of them monolithic, and in aesthetically relevant areas microveneered, buccal cutback, microveneering. And that's, I would say, that's the bread and butter of today's reconstructive dentistry.
So I have to ask you, how often are you doing monolithic versus microveneered? Or are you using lithium disilicate still? Like, what place do you think monolithic zirconia has in aesthetic cases?
Well, in highly aesthetic cases, there is, I think, no place for monolithic zirconia today still. Despite the fact that now we have graded ingots that have the best of both worlds, like the strength zirconia, the 3YTZP zirconia, which is not very aesthetic. So not to say it's almost an ugly ceramic framework material, but it's a very high stable, high strength ceramic material. And then you have a more translucent zirconia, 5Y zirconia at the part of the incisal edges and the occlusal regions, which improves the aesthetics, but in highly aesthetic areas, purely monolithic, it's, I think, still not there. And I think one of the problems zirconia also has when you compare it to lithium disilicate is that it has a very high light refractory index. So light falling on zirconia gets reflected in a very different way than when it falls on lithium disilicate, which very frequently makes zirconia restorations lighter in the clinical situations than the teeth next to it. Although they look nice in the drying, when you cement them and you look at them in the different light conditions, you see, So that's maybe where lithium disilicate comes in.
Okay.
So this is where we are today. I would say maybe it's a little bit exaggerated to say, but my feeling is really that this evolution of zirconia and the success of zirconia has induced a little bit all the development of these technologies, connecting them, because CAD/CAM was there before zirconia already, but really took off with zirconia. Yeah. And now we have all the tools at hand. We can communicate with patients using augmented reality. We have virtual patient planning tools, and that's where your AI comes in that you just mentioned. And then we can translate the plan that we communicated to the patient very predictably by copy-pasting it with CAD/CAM procedures into blocks of materials. And all of it supported by artificial intelligence will only get better and better with the years. And I think the next step, and it's already there, is to use mixed reality glasses to have all the needed information there where you need it and not in 25 screens around you. So I think that we have a very, very exciting time in dentistry at the moment.
What do you think of the limitations of AI for clinicians making this transformation into full digital workflow cases using AI?
Well, it's still in dentistry a recent technology, and AI can only be as good as the information that it uses for whatever we want it to do for. And I think there will be a strong need for validating the different AI tools to make sure that they deliver the right information to the clinicians, so that the clinicians that are less experienced and less knowledgeable can really trust on what they receive as a proposal. And when it comes to treatment planning, it's the same thing. You need huge data sets of patients, and then you need a lot of evidence that is fed into the AI to really spit out the right thing for the right patient. And I think it will take some time to get there, but we're on the way. Yes, so that's a patient case that really nicely shows the advantages of the technology. That's a case treated by Juan Legas, who did his postgraduate program with us in Geneva. He's now a specialist for reconstructive dentistry. And that's a lady that came with the wish to replace the removable prosthesis that she had since many years in the upper jaw with a fixed solution. So she came with this situation that you can see on the radiograph with some not very well, I would say, situated teeth in the maxilla, a molar in the left side of her mandible that was failing, and some residual teeth which were periodontally treated in the meantime and stable. So maybe you can go one slide further. And this lady really, she had the wish, I really want to have a fixed solution. I was wearing this prosthesis for more than 30 years now. She lost her teeth early on. And you can imagine the maxilla was quite resorbed, and the prosthesis was sort of compensating for a lot of loss of tissues, hard and soft tissues beneath the lip. She looked nice. She looked almost like class 2. Go for one slide further, please. She had a diastema that she wanted to keep. That was one of her prerequisites. She wanted a fixed solution. That was the second wish. And the third one is to keep at least the canine in the maxilla, because she was really happy to have one healthy tooth there and she wanted to hold on to it. If you go on further.
Yeah, I got a question about that. So
yes.
What do you share with your resident students about the need to understanding analog planning and execution? For example, in this case, if number 11 failed and that the OVD is being held in that area or becomes decayed and cracks, it happened to me in the same situation. How do you teach this to the residents? Because this is so important, and a lot of the residents don't want to grab onto analog because it's outdated, but it's far from outdated. So can you share with us?
To analog, how do you mean to analog? To analog analysis of the case or analog?
Yes, you have to step, you're doing fully digital work up here. Yes. And number 11 fails. Everything's based on number 11. Say the day of the surgery, number 11's broken or needs to be extracted for whatever reason, or she comes in with the tooth extracted.
Well,
how do you choose things there to go out?
This is a removable prosthesis which was already with the number 11 in place, and it was not fixed on the number 11. So if we would redo a removable prosthesis, the tooth could be there, and we would not be, I would say, worried about losing it, because if you lose it, you can extend the prosthesis. But if we plan for a fixed solution now, and maybe you go one slide further.
But the question I got, though, you're using the surgical guide that's sitting on number 11, correct?
Yes.
Because
So
that
with-
could be an issue with stabilizing the guide is
Yeah,
might be the surgeon's point.
Exactly. So even if the tooth would have been in a worse condition and deemed to be extracted for the fixed solution on implants in the end, we would have kept it for the transition phase, first of all, to give us a little bit of perception during the provisional status, to give us a retention for the provisional, to help us with the diagnostics, and that's the most important part, to stabilize the guide during the surgery. So we were aiming for keeping as many teeth as possible, at least during the transition phase.
Okay.
And
I just noticed when you go to the next slide, in the way that you had designed, or it might be in a couple slides, but the way you had designed it, you also used the hard palette. So if worse comes to worse, you do have part of that integrated into your designing process to be able to utilize something.
Very good
physical.
point, Briar. Yep, correct.
Yes, exactly. But we were still very grateful to have the canine in place there, because it really helped us stabilize the position of the guide. And as said, it's a patient case where now you have to do a lot of pre-prosthetic analysis and diagnostics with her to make her understand what we're talking about, because we were worried that we would not be able to do a fixed solution without large surgical interventions to augment the maxilla. And she was not really very much willing to have more surgeries in addition, but we had to make her understand why we would consider it. So we were analyzing the influence of the buccal flange, trying to make her understand that maybe her facial tissues may collapse if there is no buccal flange anymore, like the prosthesis had it. And if you go on the next slide, please. And for this, we used technologies to communicate. So we made a scan of course, her face. We made a scan of the prosthesis, the whole intraoral situation, and the guide. The next slide, please. And the maxilla without the prosthesis, and we made a scan of the prosthesis itself. So we had a lot of digital files now that helped us plan the case and communicate to the patient. So if you go to the next slide, what we've done is we printed the prosthesis that we just scanned in resin, and then we removed, click one more please, remove the buccal flange of this printed version. And now she has two options to try in, like shoes. She has the prosthesis with the flange and the copy of the prosthesis without the flange. And then we can discuss the compromises and the problems of it and the potentially needed surgical interventions if she really wants to have a fixed solution. So that's a really strong tool for us to plan. And then the next slide, please. We can look into her facial aesthetics. Looks quite nice still, but she looks like she's forcing her lips to close, like a class 2 relationship. Go on to the next slide, please. And now we have to talk to her to see whether we can move the teeth a little bit more to the palate without removing the diastema, because she definitely wanted to have at least a small diastema, but making it smaller and making a bit less, reduce the need for the surgical augmentation procedures. Go to the next slide. And now we use the technology once more, because we have the scan of the prosthesis and we can move the teeth now to the right position. More palatal. One more click, please. And one more. And we can analyze now whether the axis of the teeth, if placed where the bone is, if placed where the ridge is, would be aesthetically acceptable for her, or whether they would be in a bucco-oral direction, too much inclined and still aesthetically not pleasant enough. So we have a tool that now helps us again evaluate, give her time to take it home, talk to her family, make up her mind. And once she decided, no, that's it, that's fine. One more slide, please. We have a file that we use now through all the next treatment steps. So we copy paste this plan into the guided surgical planning. One more click, please. We planned segmented solution, not a full arch, which would have, of course, been a little bit easier, but we wanted to keep the canine. Next slide, please. And then the implants were placed according to this prosthetic plan. And at the next step, we take an optical impression of this. One more slide, one more click, please. We can translate this virtual plan now into a physical provisional, a temporary that she can wear for some time while we modify a little bit the emergence profile of the soft tissues. She can test what we had defined with her together as a final treatment goal. We can still modify everything. Click once more.
And I'm assuming those were milled provisionals or prototypes?
Yes, exactly. Those are milled prototypes made out of PMMA blocks, and they are provisional that she can now wear for a couple of weeks, which gives her a good evaluation period adaptation period before we go into the final situation. And we can still adapt it and then mill the final a little bit differently than the provisional was done.
And it's the final blueprint, basically, of the final print, which is nice. And I like that you broke the case up in multiple sections. At least that's what I believe you did at the end, correct?
Well, yes, because this is something I would say maybe it's very much a Swiss concept to have segmented solutions, because if you have a problem with one of the implants, it's not the whole arch that is. We are not doing that many full arch restorations on this side of the planet.
Yep.
But also in her case, it was because of the canine,
Yep. Yeah.
And there's some benefits to keeping that canine other than just patient preference. Like you have quite a few benefits. Can you tell us a little bit more about some of those and why you would, not try to convince the patient to extract that tooth, but you found value in keeping it?
Well, the first value was, of course, to stabilize the surgical stent, but the value for her now on lifetime is that she has a perception that is different on this tooth than on the implants around it. So she will always have a little bit more feeling than if we would have taken out this canine and just loaded the implants. It's 8 times more load that implants can bear, while the perception of a tooth is much more 8 times higher than the one of the implants. So she will be protecting in a way also the implant restorations with the aid of the canine. Yeah.
Totally.
So I have to ask from a prosthodontist standpoint, what was your guidance, your occlusal scheme? Did you go with canine guidance on that canine, or did you go with group function?
No, we did an occlusal canine guidance in this patient. So this is the patient with the finalized situations. Once more, it's Juan Legas who treated the patient together with Vincent Famer, who did the dental technical work. And we're trying to establish canine guidance in cases where we have the canine present, like in her case, with the perception that the canine has, and also to, I would say, lower the risk for having fractures of the ceramic in the buccal cusps of the molars and premolars. And canine guidance is prosthetically maybe a concept that is easier technically to translate, but it's not worse than a group function. Group function would have worked as well. It's just a little bit more risk that you have some fractures, superficial fractures, than on the premolars and molars. And those are zirconia restorations. And these zirconia restorations are made out of the graded blanks with translucency in the incisal border, with the strength in the core, where you have also the connectors, and with the buccal microveneering to fulfill her aesthetic needs. So if you look into where we are today with technologies, we can say they definitely improve the quality of life of the patients. And you could see this in this patient. She really changed her hairstyle. She really smiled. She's happy. She's closing the diastema and the lower jaw now. She considers to close the diastema of our final restorations in the upper jaws as well. So you see how the mind changes with prosthodontics. And this is what I love the most about our field. You change the patient's life so much just by giving them teeth and aesthetics.
And the retrievability you enabled to happen.
Yes.
Still retained in sections. So you can do whatever you want there. So
yes.
Planning for the future.
In principle, yes. Yes. And it's less expensive than the past types of restorations where you would have a manually made gold cast framework veneered manually with veneering ceramic, which was very, very expensive in the past. I think today these types of restorations become more affordable.
Right.
You have less sessions on the chair, less time is involved. So in principle, I think we are having the tools at hand to have a better dentistry.
Okay.
And speaking of the future and kind of this case, as far as the 3D printing is concerned, I know you utilize that for kind of a mock-up trial run, but what other uses do you foresee as viable uses or limitations for 3D printing?
I think 3D printing is the future technology that becomes stronger and stronger with each month. There's a lot of development on the material side. It is definitely a technology which allows for more accuracy and also more sustainability. It's environmentally more interesting than the milling procedures are. It is a technology which so far is mostly focusing on resins, and that's maybe a little bit the limitation at the moment, but I think also this limitation is changing very quickly. We use it for guides, we use it for mock-ups, we use the printing technology for maybe also like occlusal stents, not Michigan splints, but splints to protect restorations. But we see technologies coming up with hybrid materials, like they call it, how would they call it? I don't remember anymore. It's like a mixture of resin with a lot of ceramic fillers, which are now also being advocated for final restorations, supported by implants and teeth. We are having a researcher here at the University of Geneva who does a lot of high-level research in the field of onlays and overlays with this 3D printing technique. I'm not sure how these restorations will perform over medium to long term. I can judge a lot the ceramic performance, and there is ceramics that after 5 years perform excellently, and lithium disilicate and zirconia belong to those. The resins, they exhibit more wear, and they exhibit, I would say, a faster aging of the materials. So if these new nano ceramic type of hybrid resins can improve this, we'll see.
I'd love us to be able to get through this case, which is a lovely anterior case.
You want to get to this? Okay, that's a case where really technology helps us to be predictable. So this is a patient losing these incisors, unfortunately. So that's the tooth number 8, 9, and 10 in the American system, right?
Yes.
So it's 1, 1, 2, 1, and 2, 2 in our system. And this patient came with these teeth and is now really unhappy to hear that there's a lot of problems and that they do not have a good prognosis. So maybe go one slide further. And it's a case where, again, our treatment starts with a proper analysis of the case, a diagnostics, a definition of the prognosis of the teeth, and then a definition of the final treatment goal by trying it in and communicating with the patient through a mock-up. Once the patient, one slide further, please, defined that this is the shape that she or he wants, then in her case now, after proper analysis of the bony situation, the cone beam CT, the mock-up, so the prosthetic plan, and the anatomical situation, the decision by the clinician, in this case it's Dr. Joao Pita, is one of our faculty in our team. He decided to do an immediate loading in this situation. So to help the patient transition from fixed own teeth to fixed implant-supported teeth without a provisional phase where she would have to have a resin bonded bridge or a flipper or something. So the teeth were very carefully extracted. The implants were placed according to the guided surgical plan, so prosthetically oriented, and then bone regeneration and also some resorption prophylaxis was made in the pontic region. One slide further. And then at the same time, because of the stability of the implant and maybe also a little bit the design of the implants that allowed for immediate loading, the provisional was inserted, a screw-retained provisional adapted clinically to the position of the implants, but prepared beforehand, like a little bit eggshell, but not really eggshell, but leaving space for adaptation after placement of the implants according to the mock-up. And now, one slide further, please. Now we can have a 3-unit screw-retainable prosthesis supported by these implants in least load and function as possible to help the patient leave the operative environment with teeth again, which psychologically helps her, but at the same time also helps us keep the shape of the soft tissues, guide the soft tissue emergence profile according to the prosthetic plan, and test the aesthetics over time. So 1 week later looked already very well. She was, move on one more slide, please. She was very happy, not much pain, not a lot of swelling, and she left with fixed teeth. So she was really very happy. And all of this because we could plan it with technology to be as easy and efficient and straightforward as possible as intervention.
And the ridge maintenance on the pontic and looking at the soft tissue convexity is just beautiful. And the thickness of the tissues and the periodontal phenotype looks marvelous. So beautiful job in here, the whole team. I mean, this is a whole team effort. It's really amazing. So
that's true, but I also have to say that Joao is a great clinician, and then he finished the case together with Vincent, who is a great technician. So it was also a good team, and the patient was very compliant. So I think all in all, these are all factors that are very important for the success of prosthodontics. Mm-hmm. So now we take the optical impression for the final restoration. One more slide, please. And then it can be milled out of the zirconia once more time, the graded zirconia, adapted to the emergence profile and the contours of the soft tissues, and delivered in a very efficient, straightforward way. allowing the soft tissues now really to adapt to it, to heal. The soft tissues are in contact with high gloss polished zirconia, and only the visible part, the aesthetically relevant parts, are micro-veneered without veneering ceramic in the functional areas. So the incisal border, just the last millimeter, is zirconia, no veneering ceramic. So it's really like a window on the buccal side to look nice, but there's no function on the veneering ceramic. And with this, we're doing a study right now. We're testing if we can really reduce the chipping rates even for those types of restorations.
What is the predominant, with these materials, complications? Because I'm sure you're looking at that like you did with the publications in 2010, 2007 area. What are you seeing?
Well, we are seeing with the microveneering problems with chipping as well in our early cases, but it was because the microveneering was applied on the buccal side up to the incisal border, up to the cusp tip, where the transition zone between the core of the crown and the veneering ceramic was within functional movements. And whenever there is a movement coming from a core material to the weaker chipping, weaker veneering ceramic, the risk for chipping is higher. Yeah. So that's why now we're really trying to avoid this. We don't see a lot of decementation. That's a very positive finding because this was one of the first worries with the whole concept. Yep. And we see very good biologic outcomes. So we see marginal bone loss stability. In specific cases, it's not as good as in others, but I think today we know that also the emergence angle plays a very crucial role. Yep. Coming out of these implants and how these restorations are designed. So I think the learning curve now allows for really predictable outcomes. So that's, I think, something interesting because we started, Briar, you asked me about 3D printing, and I think today it's still mostly resins, but there is a lot of research in printing ceramics. And I think with lithium disilicate, the researchers are quite successful already, and zirconia is in development. And you see, now it's 2025. We were working on 3D printing of zirconia when I was in the US for the first time in 2009 already at NYU with Van Thompson. Van Thompson, Di, and Rico, also great mentors that I had in my pathway. They were working on a process that at that time was called robocasting. And it was also published. I think Nelson Silva published on this. They tried to 3D print zirconia already then. And that's such a long time ago. And now it's getting slowly but surely in an area where it would be doable, but it's still not there. So these developments, although for all the young generations of dentists, they look like they were always there, and that's clear that we have them and it's easy to use them, it's not that evident. It takes 20, 30 years of development, and then also after development of acceptance of new technologies to get where we are today. And I think that's, for me, what was the biggest learning curve to see, wow, in 2007, there were already first pioneers working on this, and we're now in 25, and it's still not there. It may take a couple of more years. But then in the future, I think I see us one day really take an optical impression where the scanners that are getting more and more intelligent and versatile will be able to really see everything. The tooth, its shade, its optical properties, its strength, and we will 3D print the tooth next to the patient, chair side, just exactly the same way we reproduce it. Well, that's something to make you aware that this is an online-only supplement that we made last year with two really, I would say, very well-known invited editors, Professors Burak Yilmaz and Amir Zandi, both working intensely on the field of 3D printing, and there is a lot of open access articles that might be interesting for the young residents in research.
Okay, next slide. Know these people.
Exactly. That's the book that you mentioned in the beginning, Briar. That was a great work that we've done just before the pandemic and finished. And then when it was supposed to be published, the pandemic hit the world. And then it took, I think, a year longer for Quintessence to release it. But we had a great time together publishing the work of the last maybe 20 years that we've done.
Okay. Well, let's go to our last slide. So this is to wrap things up. I want to say thank you to everybody for coming, but this is one of the most important slides, personally speaking, because I just love reading, and we all do love reading. We started with AI Revolution, the Future Care and Treating People and Patients. That was with Will Ginobili and Lorenzo Tavelli recommendations. Then we went to Dr. Tarnow and Joe Kahn and the books under the Surrounded by Green. And now let's talk about, Irena, your books. It's Surrounded by the Orange. Sam Walton, and also You Become What You Think.
Well, Sam Walton is a book that I really read with great interest because I was invited by the American Academy of Aesthetic Dentistry past president Rick Robley to Arkansas. And this was in the context of the Newport Harbor Study Club that I gave a lecture for. And I came to this little city and I learned just by talking to everybody there that this was the origin of Sam Walton. And Sam Walton was the one who invented Walmart, who made Walmart what it is still today. And then they took me to his birth house, that's museum, and I bought this book and I read it because it was so interesting to see how they started from zero with a good idea and with persistence and a good team and, believing in what you do, you can achieve something incredible.
Yeah, a lot of these books are leadership books, team-oriented. Briar, could you share about Outlive?
Yes, so Outlive is a book about the science and art of longevity. And part of the reason I put this is we would like to see people like Dr. Sailer living longer. Our patients are living longer, continuing to increase the field and the knowledge we have. And it talks a lot about taking care of yourself and understanding what you can do to make yourself healthy and be able to enjoy life more when you are older. So.
Yes. And I edited a history book, Blue Latitudes. It's about James Cook circumnavigating the world 3 times. One of them was during the American Revolution. He never knew what was going on. Fascinating from the diaries. A lot of my books are historically oriented, so I'm a big history buff. So I want to say thank you, everybody. Remember, keys to happiness: read a book, take a hike, reconnect with an old friend, and also hang out with Irena and Briar. So I want to say thank you all today. And wonderful discussion, as it always is. So any questions? I think we're good. So I want to say ciao to all. Our next slide, please. I forgot we want to highlight. I visited P.D. Miller at his retirement home back in April. We had virtually Alex Lynn and Cheyenne Barucci. The evolution of soft tissue grafting and the art of tooth preservation is very important because of what we need to know about phenotype. Really started with a lot of his forward thinking, and PD will be talking about that. That's one of my closest mentors, some of my mentors. So I want to say on that note again, Irena, thank you. Briar, thank you. And we'll see each other soon. And signing out from Philadelphia, Briar and Bob. So
thank you very much for having me. And I'm signing off from Geneva with New York in my background. So I'm not that far away from you, just at least from a feeling point of view.
Yeah. Always good to see you, Irena. You stay well. All right.
Likewise.
Thank you so much.
Thank you very much.
Ciao.
Thanks. Bye-bye.